Part of this morning's session. Our next speaker is the Minister of State with responsibility for primary care, Ms. Roisín Shortall. And I think all of us would hope and believe that primary care and whatever changes can be made to happen in that area will be pivotal in terms of any change for the better that will come to our health service. So Roisín was appointed Minister of State for Primary Care in the Department of Health literally this time last year, on the 10th of March last year. She was first elected to the Dáil as a TD in 1992, and she's been re-elected at every election since. As well as membership of various Dáil committees, I suppose I should particularly say that she's been a member of the Ballymun Neighbourhood Council, the Ballymun Local Drugs Task Force and the Finglas Crime Task Force. As someone who practiced in her constituency for a number of years, it gives me particular pleasure to introduce Minister Roisín Shortall.
Thank you, Marish, and good afternoon, everybody. I want to say just at the outset that I very much welcome this conference and the focus that is being placed on the whole reform agenda within health, and the importance of keeping that focus on. And this is a particularly opportune time, I think, 1 year into the government's life, to look back at the year and legitimately ask what progress is being made on that front. From my point of view, I have to say that it has been a very difficult year. I would say that it's been a particularly challenging year, not least because of the economic situation in which we're all trying to operate. I know Minister Riley made reference to this earlier, but there have been very extreme pressures on all budgets right across the government. In the health area, we've lost some €750 million from the health budget at a time when the demand for services from the health service are increasing very significantly. We also had the situation last month where a very significant number of people retired from the health service, many of those frontline people. And for that reason, I would say that at this point, given the climate that we're operating in, that reform is not only desirable, but it's absolutely essential, because we simply cannot continue to provide services in the manner in which we have been providing them over recent decades. I believe that we have no choice but to change the models of care that we are providing, and to ensure that those models of care are operating on a lower cost base than heretofore. Not only will we get better value for money and the shrinking pot of money that is being spent in the health area, but critically we will get better health outcomes. And that's why the challenge now is for us to accelerate the reform agenda and move to those models, better models of care that will ensure better outcomes for everybody. Also, I have to say, from my point of view as Minister with responsibility for primary care, and I'm very proud to be the first Minister of State with responsibility for primary care, the challenge is to keep the focus on the reform agenda. We all know the difficulty where the urgent always takes precedence over the important. The thing in health, though, is that the urgent is also important in health. So while we're dealing with the urgent, day-to-day, important issues that arise in health, we have to ensure that we make space for the ambitious reform agenda that the government has set out. And within that, I'm very conscious, as the Minister of State with responsibility for primary care, that part of my job is to make space also for primary care. Because traditionally primary care has been very much the poor relation of the health service. It has been squeezed by other sectors in the health service. And I would see my job being principally to make that kind of space and to ensure that primary care has a strong voice and that it is in effect able to compete with the other areas that have traditionally been more vocal and more powerful. And there's lots of reasons that I've discovered why that has been the case. Not least because of the fact that there isn't a national director, for example, with responsibility for primary care within the HSE. Not least because while we all agree that primary care is critically important, there isn't a ring-fenced primary care budget. There isn't a separate budget for primary care at all. So, there's money that is being spent on primary care, but traditionally and regularly other sectors in the health service dip into that budget. So we need to get clarity about the budget for primary care. We need to protect that budget and, to the greatest extent possible in the current climate, that we improve that budget. So they're the kind of challenges that are set out, the challenges that I've been grappling with, I suppose, over the past year in the context of delivering on the reform programme. And I'd like to do just a short presentation for you now on the reform programme 2012 to 2015. The agenda for me as Minister of State with responsibility for primary care, as it is for Minister Riley, is the programme for national government. And I think it's worth reminding ourselves what that programme says. This government is the first in the history of the state that is committed to developing a universal, single-tier health service which guarantees access to medical care based on need and not on income. Very profound statement at the start of the section on health in the programme for government, and a very radical and ambitious programme to set down. It is proposed that we would deliver on that programme in 2 phases. The first phase being primary care reform, and the critical element of that reform being to provide free GP care for all within the term of this government, so within the next 4 years. The second phase, as you know, is in relation to hospital reform, the introduction of universal health insurance to cover hospital care by 2016, and Minister Riley has already spoken to you about that this morning. So the objectives then of the primary care reform programme. First of all, that access to GP care would be free at the point of delivery. So we'd remove fees for GP care. We need to substantially build the capacity of primary care teams, and the point was made by a speaker earlier about the primary care strategy being a 2001 strategy and progress being disappointing in relation to the implementation of that strategy, in spite of the fact that we've come through a major boom. Progress was very slow in that area. So we need to build that capacity so primary care is fit for purpose and will be able to meet will be able to meet 90 to 95% of the health needs of the population. We need to provide a network of primary care centres. Again, a 10-year strategy, and we really only have a few dozen primary care centres, so a lot of ground to be made up there. We need to implement chronic disease management programmes. We've been talking about those for a long time. They are clearly the way to go in relation to delivering a modern and effective and cost-effective health system. And we need to accelerate the rollout of those programmes. We need to refocus health services to deliver care in the most appropriate and the lowest cost setting, which, as you know, is primary care. And as I've said already, the intention is that primary care will meet 90 to 95% of health needs. It seems extraordinary that if that is the ambition, and that has been the ambition for some time, and everybody agrees it's right, that we don't have a national director for primary care, we don't have a primary care budget. The programme for government then sets out the primary care reform measures, and those measures are to be delivered in stages. This year, 2012, we want to ensure that there are no GP fees for people who receive free medication for defined illnesses under the long-term illness scheme. So we're phasing in the introduction of free GP care, and the first phase will cover those who are current claimants under the long-term illness scheme. And when you look at the breakdown of those people claiming under that scheme at the moment, between 60 and 70% of those people have diabetes, 15 to 20% have epilepsy, and plus there are other conditions covered also, things like cystic fibrosis and others. We want to ensure that the early phases of the introduction of free GP care are designed to focus on identifiable groups who have long-term or severe illness, and that's the guiding principle. There are different ways of approaching the phasing in of free GP care, but we've taken a decision that we want to put the emphasis on the sickest people in our society, and they are the first people who will have access to the free GP care initiative. We need to phase in the introduction of free GP care so that extra doctors, nurses and other primary care professionals can be recruited, so that we can expand the capacity of primary care to meet the kind of needs and demands that we're going to place on it in the coming years. So we're talking about a new model of care then for primary care. And some of the features of this new model of care are the following. GPs will be paid primarily by capitation. GPs will work to a greater extent in primary care teams with other primary care professionals. A new GP contract will be developed so that GPs and nurses care more intensively for patients with chronic illnesses. I'll come back to that later. This, we know, will significantly reduce demands on hospitals. We're doing this because it makes sense. It makes sense from a health point of view, and it makes sense from an economic point of view. And part of the rollout of free GP care for everybody will entail compulsory registration with primary care teams, so that after the 4-year phasing in, everybody across the population will be required to be registered with a primary care team. The funding model then that we're working to is the following. Exchequer funding for primary care will go into a dedicated primary care fund. This will be a ring-fenced fund. It will be protected for the provision and development of primary care. The fund will be made up of 2 strands. First of all, the Primary Care Reimbursement Service, and that's the PCRS that operates from Finglas, that currently pays GPs and pharmacies. So the funding from that, plus the funding that's currently used for HSE primary care staff, public health nurses, OTs, community physiotherapists, other allied health professionals, and the administrative element of the HSE in relation to primary care. So those 2 elements will be brought together to form the Primary Care Fund. This chart shows how reform changes primary care funding and the question of GP fees. See the very large red slice there, portion of the cake, is the hospital funding. And the blue portion at the front there shows the primary care element that is funded by the Exchequer. The very small, slim pink slice there represents out-of-pocket GP fees. And you'll see there that that represents only 2% of total health spending. Very small proportion, 2% of total health spending, and that's equivalent of about €300 million. Now, why are we prioritising the removal of GP fees? Well, at the moment, nearly 2/3 of people pay fees for GP care. That fact means that there's no account taken of a person's ability to pay. Out of those 60%, there'd be a wide range of different income levels, and there's no recognition at all of ability to pay. The high GP charges undoubtedly deter use of care. They increase the risk of later detection of illness and higher health costs in the longer term. We know from various surveys that have been done in recent times in particular that GP fees deter people accessing care at an early stage. And very often, I think, what people are inclined to do is, where their family budgets are very tight, and many people have very tight budgets at the moment, they hope the condition goes away and they leave it unattended to. And very often, people who take that course of action end up with a more serious condition, and very often end up having to go to A&E and indeed being admitted to hospital for much more expensive forms of care. So because of that, charges for GP care increase the demand for that more expensive care in acute hospitals. We also have to be cognizant of the fact that we have an ageing population, and while I take the point that was made earlier that thankfully lots of people between the ages of 60 and 80 are living very full and very healthy lives, there is no doubt that the prevalence of chronic disease increases as a result of that. And with our ageing population, it is all the more important that we put a greater focus on primary care services and ensure that those services are fit for purpose. If we look at the effect of GP fees then, in Northern Ireland, as you know, there are no fees, and in the Republic here, 60% of people have to pay fees. In the Republic, almost 19% of patients with medical problems had not consulted a doctor because of the cost. Average GP visits are about 3.8 per person per year in Northern Ireland, where they're free. Here in the Republic, the average rate of visiting is about 3.2. So surprisingly, there isn't all that big a difference. Sometimes people think that, well, if we have free GP care, you know, the GP surgeries will be swamped. It hasn't happened in the north, and it doesn't happen elsewhere. In Northern Ireland, much more care is provided by practice nurses, so there's a different model of care there. Here in the Republic, the way in which fees are structured means that it prevents GPs from delegating care, prevents the development of a lower cost model, and we end up with a higher intensity model of care. The structure of the fees means that GPs need to be more actively involved in the care of their patients than is the case in Northern Ireland, where there's a much wider use of practice nurses. And as I've said already, fees add very little to the overall health budget, only 2%. I think it's important also to remind ourselves about what the expert group said. Payment for healthcare at the point of use conflicts with the goal of developing continuity of care. User fees are regressive, posing a greater burden on patients with lower incomes. They also said the requirement for the majority of the population to pay out of pocket for GP care is unique to Ireland compared to other developed countries. If we look then at the effect of GP fees on GP supply, by and large, historically, the state has left the provision of GP care to the market. So primary care services have by and large been located in those places where GPs have decided to locate. The consequences of this has been that there are too few GPs, there are geographical black spots which are poorly served because of an undersupply of GPs and because of GPs acting rationally and in general terms locating in those areas where there is a fee-paying market. With this government's introduction of free GP care, the state will critically take responsibility for ensuring the supply of primary care services, something that I believe the state should have always been doing, but this government very much recognises the need for the state to now take responsibility for ensuring that we have adequate provision of GP service, of primary care services right across the country. When I say there's not enough GPs, that's how we rate on an OECD basis, fairly close to the bottom. Also, the map isn't big enough to show you this, but we have mapped the entire country in relation to socio-economic profile, and we've overlaid that with the location of GP practices. And it does certainly identify, it's not clear enough there because the map is too small, but it does certainly identify a significant number of black spots, those areas that are, generally speaking, the most disadvantaged areas, the areas indeed that require the best health services and place the greatest demands on our health services, but those areas very often being the most poorly served by primary care services. And really, that's not an acceptable situation, and if we're serious about raising the health status of the population, we need to tackle that issue. A number of measures then underway to increase the supply of GP care. We are opening up access to the GMS that has been restricted traditionally. There's been a fixed number of GPs operating the GMS, and we're opening up access. We won't take all the credit for that, I must say. The Troika, as part of the Memorandum of Understanding, are very intolerant of any kind of closed shop operations in relation to the professions in particular, and they had very strong things to say about that. So they have insisted on a tight timescale for the opening up of access to the GMS, and indeed I'd say that is to be welcomed. We are in the process of increasing the number of GP training places. We will need to encourage GPs to defer retirement in order to expand capacity. We will need to recruit some of those many GPs that trained here in this country in particular at significant cost to the taxpayer, but having gone through a very expensive training, a very lengthy training, high quality training, we didn't have jobs to offer them, and that made no sense at all, and we forced many of those very bright people to leave the country because there weren't opportunities here. So we'd be very hopeful that a number of those people would come back here and get involved in modernising and developing the Irish health system. We need to increase the number of practice nurses so that GPs can delegate more care to nurses, and the funding model, again, as I'd say, has to be changed in order to facilitate that. And we need to make greater use of pharmacists to deliver care. Pharmacists are very highly qualified people, and we need their active involvement and engagement in primary care, and there are a lot of tasks that they can do. So what is the potential of a fully developed primary care system? Chronic diseases, as we know, are the leading cause of death and illness in developed countries. And about 3/4 of the health expenditure it goes on the management of chronic diseases. The clinical care programmes will shift management of chronic diseases from hospitals to the community. The diabetes programme is very well advanced, and implementation will begin this year. I'm very glad to say that there is funding provided in the budget for the rollout of that programme later this year. And work is well underway on developing programmes in relation to stroke, heart failure, asthma, chronic obstructive COPD, dermatology, rheumatology and care of older people, with a view to those being rolled out in the coming years. If we look at the diabetes programme, that is the biggie, of course, and that has the potential to radically transform how we deliver services. And I think it's worth just looking at some of the detail of that. I'll run through it quickly. 3% of the adult population has a diagnosis of diabetes, with an unknown number undiagnosed, and those numbers, the prevalence, set to increase over the diabetes programme, because it will mean that all people with diabetes will be brought into the programme. Over 50% of patients could be managed at primary care. A further 1/3 of cases could be shared, their management could be shared between primary care and acute care. The diabetes programme will reduce hospital stays for diabetes patients and over-reliance on hospital outpatient services. GPs, practice nurses, supported by community diabetes nurse specialists, will be delivering that programme. The diabetes programme has enormous potential. It would reduce deaths from diabetes by about 10% over the next 10 years. It would reduce blindness by 40% in the next 5 years, reduce leg amputations by 40% in the next 5 years also, and reduce heart attacks by 20% over the next decade. It would also, in terms of making sense on a whole lot of different fronts, in terms of the impact of that on acute hospitals, you'll see there about 9,500 bed days would be saved through the treatment of foot ulcers at primary care level. It would save 4,500 beds over the next 5 years by reducing the need for amputations. The impact of the improvements in relation to stroke would save about 5,500 bed days. And in relation to heart attack in diabetes, over 4,000 bed days would be saved. So, what have we been doing so far in relation to delivering on this ambitious reform programme? The actions that are underway. A universal primary care project team of officials from the Department of Health and the HSE has been established and is meeting fortnightly. It is the responsibility of that project team to roll out the primary care reforms and to address and tease out and scrutinise all of those complex issues that are involved in delivery of this primary care programme. The Health Provision of General Practitioner Services, that Act, has recently been signed into law, and that will commence this month, and that enables us to open up access to the GMS and should be an encouragement for young GPs, hopefully who are qualifying this year, to remain in Ireland. We were saying to them very clearly, there will now be opportunities for you to be part of primary care services this year, and we want you to stay in Ireland after you qualify. A needs analysis of the priority areas of greatest need for the development of primary care centres has been completed by the HSE, and this will inform decisions in relation to the future location of primary care centres delivered by the state. A model of GP and practice nurse supply and demand has been developed by researchers in Trinity and in the SRI to inform workforce planning. And in that regard, I want to very much acknowledge the input of two of our speakers here this morning, Steve Thomas and Richard Late, into that important piece of work. That's a model that has now been developed, that is now the property of the Department of Health, and will be a very important tool in ensuring that we have the capacity to develop primary care services in the way that we want to, in respect of GPs and practice nurses. Critically, a figure of €15 million has been provided in this year's budget to fund GP care for people from the LTI scheme. There's quite a battle in the context of all of the pressures on the budgets, and in spite of the fact that it was in the programme for government, you still have to battle for literally every euro that you get in the health budget. So I'm very pleased that there is a figure of 15 million there ring-fenced for the reforms this year. This opens up the opportunity, of course, as I've said, to roll out the diabetes programme later this year, and there is a figure of 2 million provided in the budget this year for the start of the diabetes programme later on this year. So what else has to be done immediately? These are the immediate next steps that need to be taken. We need a bill for the extension of free GP care to people with defined long-term illnesses under the LTI. A lot of preparatory work has already been done in that regard. There are a lot of issues that need to be dealt with, and they have been teased out, and we're at a very advanced stage in the preparation of that piece of legislation. A new primary care directorate with clear leadership and responsibility for the implementation of the primary care reform centrally and locally is in the pipeline, and I know Minister Riley spoke to you about that, about the kind of reforms that will be provided for in the legislation coming before the summer to establish separate directorates within the HSE, and one of those obviously is the Primary Care Directorate. The creation of the Primary Care Fund is provided for under the Programme for Government, which I've referred to already. I've told you about the make-up of that fund, and the ring-fencing of that funding needs to happen as soon as possible. Capital allocation for primary care centres to be prioritised in the areas of greatest need. And I note a question that was asked about this before the coffee break. Again, I would say that the the government is very determined that we would take responsibility for the provision of services and accommodation for the delivery of those services right across the country, and we're in negotiations at the moment in relation to the actual allocation within the overall capital budget for health, and we are very hopeful that we will have a pot of money, in difficult circumstances, and not as big a pot of money as we'd like, but that we will have a pot of money to start the procurement of those premises in order for us to enhance the delivery of primary care, and that will be done on a priority basis, on the basis of socio-economic profiling that we've already engaged in. That will also entail the development of a GP contract which reflects this new model of care. So I'm leaving it at that. That's a quick run through what we're doing, and thank you very much for your attention.